policies help make sure that we're giving patients the right education and discharge instructions. Radiation doesn't end when the syringe is empty. Patients go home with potential radioactive exposure. They need to know how to protect their families, what precautions to take, and what healthcare providers can do if something goes wrong, like a spill, extravasation, or even a pregnant staff member who's involved in the care. This isn't just a documentation exercise. It's about making sure every part of the system speaks the same language when it comes to safety, handling, and patient care.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Ella-Mae Shupe, Nurse Practice and Professional Development Specialist for Radiation Oncology at Johns Hopkins Health System Sidney Kimmel Cancer Center based in Baltimore, Maryland, about creating and implementing radiopharmaceutical policies and procedures. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome. Thanks so much for joining us today, Ella-Mae.
Well, thank you for having me and discussing this topic.
So let's start off. If you could, provide us a brief overview of what radiopharmaceuticals are and how they're administered in the oncology setting.
Okay, there's a lot to that question. As you know, the topic of radiopharmaceuticals is growing for our cancer patients, and the outcome and quality of life that these radiopharmaceuticals are offering our patients has been stunning to witness. If you're a football fan, you'll probably have seen the commercials for Pluvicto during the game, so word of mouth is spreading. In fact, Pluvicto has shown so effective in clinical studies that the FDA recently approved expanded use, and it can now be given prior to chemotherapy. Radiopharmaceuticals offer a unique type of treatment for our cancer patients. There are typically three parts to a radiopharmaceutical. One is a radioisotope, which emits the radiation. The second is a targeting molecule, which directs the compound to a specific site. And the third is a linker that binds the isotope to the targeting molecules securely. The targeting molecule is usually a substance that binds specifically to receptors, antigens, or metabolic pathways that are overexpressed on cancer cells. For example, Pluvicto attaches to PSMA inhibitors on prostate cancer. Once a radiopharmaceutical is administered, the targeting molecule circles in the bloodstream, seeks out and binds to the specific receptors, and then accumulates at the tumor site, providing direct radiation in areas that typical radiation can't penetrate to the direct local level of a radiopharmaceutical. This allows non-invasive tumor localization and systemic treatment with minimal damage to surrounding tissues, which is exciting. In our oncology setting, radiopharmaceuticals are administered via IV push by the provider. This is a shift from previous protocols, as Pluvicto, which was administered by gravity infusion until January of 2025. The new method reflects updates provided by the manufacturer and supports more controlled delivery. So I'm just going to go a little bit with our setup. So pre-administration safety and prep. We have an interdisciplinary team involvement. There's a physicist, nurse, and provider that confirm lab values are within normal limits. The patient meets all the clinical and safety criteria for administration. Second is an IV placement. A nurse or the clin tech starts the IV and verifies a strong blood return. This is critical to avoid extravasation, which can be harmful due to the vesicant-like nature of radiopharmaceuticals. And third, our patient voids immediately before the injection, which reduces bladder radiation dose. During the administration, our provider administers the radiopharmaceutical using a shielded syringe holder to reduce radiation exposure. The physicist remains present throughout the procedure. Lead aprons are worn by any team members close to the IV site, and then the Geiger counter is used by physics to measure ionizing radiation, which is done before, during, and after the procedure. They scan staff, the patient, and the room, and they ensure that there's no residual radioactivity after the patient is discharged. And last of all, following administration, the patient is discharged directly home and begins radiation safety precautions as is instructed. These typically include time, distance, and hygiene guidelines to minimize radiation exposure to others.
Thank you for that very comprehensive overview. Now, you've provided Pluvicto as sort of a primary example. Does your organization give any other radiopharmaceuticals as well?
We do, and I'm going to go into that a little bit. In radiation oncology, we do Xofigo and we do Pluvicto, and then our nuclear med department does Lutathera and Pluvicto.
So talk a little bit now about how you experienced the role of policies and what role did policies play in setting up this very complex radiopharmaceutical administration process?
Okay, well, let's be real. Most people roll their eyes the minute they hear the word policy. But here's the thing. Policies around radiopharmaceuticals aren't about red tape. They're really about protection. They're in place to make sure that work is done safely, legally, and consistently. And that protects our patients, our staff, and our institution. So let me break that down a little bit more. First, because we offer this service at 2 Johns Hopkins locations, policies make sure that we're doing it the same way every time at both sites. No guesswork, no variation. Whether it's Pluvicto or another therapeutic, the process should look the same no matter where it's given or by whom. Second, policies make sure we're in line with radiation safety laws and standards, which include state, federal, and institutional guidelines. That includes the Nuclear Regulatory Commission, surprisingly, the Department of Transportation, which regulates the transportation of radioactive material, and OSHA, for examples. Policies also enforce ALERA. That's as low as reasonably achievable, which is the foundation for radiation safety. Policies also spell out who is allowed to handle, administer, and dispose of radiopharmaceuticals, and what training and documentation and certifications are required. It keeps us compliant and protects every person involved in the process. Third, policies create consistency in practice. Who orders the dose? Who verifies it? Who documents it? How is it transported and stored? And who gives it and how? Having clear answers to these questions mean fewer errors and smoother care. Fourth, they define roles and responsibilities, which means when it comes to things like charting, audits, licensure, and accreditation, when we're inspected or something unexpected happens, this clarity really matters. And finally, policies help make sure that we're giving patients the right education and discharge instructions. Radiation doesn't end when the syringe is empty. Patients go home with potential radioactive exposure. They need to know how to protect their families, what precautions to take, and what healthcare providers can do if something goes wrong, like a spill, extravasation, or even a pregnant staff member who's involved in the care.
As a clinical nurse specialist, policies are my love language. And so I love all of this. This is all wonderful.
I love writing policies.
Music to my ears. But you're right. Sometimes there's that glazed over look the minute policies are brought up or like news. But you've just provided a great comprehensive overview of why they are so important and really the role that they can play, not only in radiopharmaceutical administration, but any other high risk type of activity that nurses are performing. And we do a lot of that in oncology. So I appreciate that. And I support you and I champion that wonderful overview.
And I have a fellow nerd policymaker with me. I like it.
That's great. This is going to be a wonderful conversation. So now that you've given us that great explanation of why they're important, talk a little bit about your experience when you were creating these policies and implementing them in your organization. Why did your institution decide to create policies specifically around radiopharmaceutical administration?
Well, traditionally, radiopharmaceuticals were given in nuclear medicine. But when Pluvicto became a reality, we made a very intentional decision to keep our prostate cancer patients in radiation oncology. Why? Because they already knew the staff, they knew the space, and we wanted to preserve that continuity of care. At that time, we were already administering Xofigo, so it wasn't really entirely new, but our provider had been involved in Pluvicto clinical trials, and we knew that the FDA approval was coming. So about a year in advance, conversations began on how to build the infrastructure to support this new therapy as well as policy builds. Since we were adding a second radiopharmaceutical, and we believe there are more coming down the pipeline for other diseases, we realized we needed to take a step back. So rather than just preparing a separate policy for every drug, we decided to build a broader, more inclusive radiopharmaceutical policy, including our existing Xofigo policy as a starting point. To do this, we pulled together a multidisciplinary team. We had providers, primary nurses, physics, dosimetrists, radiation safety officers, administrators, directors, and myself as the nursing practice and professional development specialist. The goal was to create a policy that worked not just on paper, but in a real-life clinical flow. The resulting policy outlines procedures for both Xofigo and Pluvicto. It includes drug-specific competencies, detailed patient take-home instructions, and an extravasation checklist. We also developed a standard operating procedure for what to do if a patient returns to any of our institutional sites and needs labs or urine tested within 48 hours of receiving a radiopharmaceutical, which may have some low levels of radioactivity. This lab SOP was built in collaboration with lab directors across the system to ensure the right safety measures and protocols are in place system-wide and not just in radiation oncology. And right now, we're looking at the process of expanding this even further. We're looking at developing a system-wide radiopharmaceutical policy. So any department, any staff member across the institution knows exactly what to do if a patient presents within 48 hours of treatment. This broader policy will eventually replace the one that's currently lives in our radiation oncology manual. This isn't just a documentation exercise. It's about making sure every part of the system speaks the same language when it comes to safety, handling, and patient care. As radiopharmaceuticals become more common across disease sites, this kind of coordination is essential.
Well, thank you for that response. I mean, I think it just, again, shows how complex a single drug can be when it involves all these different partners. And you mentioned several key partners that are involved in this process. And so I think it just highlights not only, even in a single location, how complex it can be. And as you mentioned, trying to standardize this process throughout a system, a health system, the right thing to do, absolutely, because we want that consistency. We want everyone at every site to get the best possible care, deliver the safest way, but to be able to harness all of these different players in that system, but make sure they have the information that they need, a single kind of centralized documentation of how to do that. It seems pretty obvious that that would be necessary. So it's very admirable that you're able to take this challenge on.
It's been fun.
So what kinds of policies did you find that you needed to support your practice, and what key partners did you involve in that process of creating them?
The policy we created doesn't just address general principles. It includes very specific guidance for both Xofigo and Pluvicto. That includes everything from determining patient eligibility to completing the treatment directive, confirming patient identity, verifying delivery parameters, documenting the treatment itself, and ensuring the treatment environment is appropriate and safe. We've also built in drug-specific practices because Xofigo and Pluvicto each come with their own considerations. This includes competencies for nursing, tailored patient education for each therapy, and extravasation checklist that outlines what to do and who's responsible for tasks if infiltration occurs. And thankfully, we have never had one at our institution yet, and hopefully we'll never will. We also added a few new tools to strengthen system-wide safety. One is the lab processes SOP that I discussed, and the other is a standardized precaution sign that can be placed on the patient's door to alert staff appropriately within the 48-hour window timeframe. That is an example of how we have standardized care across our sites. These updates help make sure that no matter where the patient shows up in the system, we have a consistent, safe approach that protects both patient and staff and not just our department practice.
Outstanding. Just really interesting to hear how your process unfolded and all the different steps and people that you included so that everyone was represented in that process and everyone had a chance to contribute to developing this comprehensive policy that really spoke to every unique person's involvement in the care of that patient.
And I have to say, this came in pieces. We started with some education, and then I would get a phone call from the ED director going, hey, what if I have to draw labs? And we had not thought of that. Or, hey, what if they're in the room and we are just putting a sign up? It did not all come overnight. We did some pieces and bits, and then we got more information from other stakeholders that were like, we don't know what to do here, or how do we handle this? So, as you're building these policies, more things will come out as patients come in or they get more information and education, and things that you haven't even thought about because you don't work in the ED will start becoming part of your policy.
Absolutely. And I think, it just shows that you do the best you can, putting the best policy forward, but it is an iterative process where as new things change, as you learn new things or what you thought was going to work, maybe it's not working anymore. Like, it is that constant evolution. And that's why we have to review policies every so often to make sure that as we evolve the practice that we find is what is needed, then we also then reflect that back in the policy that is our reference document for that. So
absolutely.
I love it. Who doesn't love policies? So talk to me, what do you think the most successful strategies were to help educate your staff across your organization, across the system, about creating buy-in for implementation of this new process?
Well, this initiative was really important to our department. Now, I'll be honest, the chance of a patient re-entering the system within 48 hours of receiving a radiopharmaceutical is really low. But the reality is it did happen. And once it did, we knew that we had a responsibility to act. So we made a commitment to provide education, not just to our department, but across the entire organization. I am so thankful that I work in an institution that values and listens to subject matter experts. To move this forward, we presented our proposed education plan to our education system-wide education committee. That was a mouthful. We had to explain exactly what we wanted to teach and why it mattered. We partnered with the educator for radiology, and she covers nuclear medicine, our radiation oncology safety officer, and safety officers from multiple sites across the system. And together we created an attestation model that covered the basics of radiopharmaceuticals and the safety precautions staff needed to follow within the first 48 hours after the patient receives one. Over 2,100 staff completed that attestation. And because of this valuable information, the education department took the key component from attestation and built it into our annual required bundle education, which every employee completes every year. We created two separate versions, one for clinical staff and one for non-clinical staff. Well, why include non-clinical staff? Because the risks extend beyond just the clinical team. What if environmental services comes in to clean and the patient has urinated on the floor? Or what if dietary delivers a tray and moves a urinal without knowing the risk? Or what if transport comes in and handles an incontinent brief without awareness? So each of these scenarios has potential for contamination and exposure, and that's exactly why education for all roles matter. We were really specific in our department. We've had a really excited team to get going on these radiopharmaceuticals. And because of the patient outcomes that we see and their quality of life is so improved, it's been really easy for buy-in on our staff side.
And we know it doesn't always go to plan. What were some of the challenges that you faced or that you encountered while you were creating and implementing your policies?
Well, combining department policies and processes and educational approaches isn't easy, and it can definitely be a challenge. So you're bringing together different ways of thinking, different workflows and people, and that takes time, communication, and sometimes a few tough conversations. But what made it work for us was the passion and commitment that each department, and I'm talking nuclear medicine and ourselves, brought to the table. Everyone was focused on the same goal, which was patient safety and staff safety. And when that's the shared priority, it opens the door for real discussions, healthy compromise, and even a little creativity. I really believe that when your heart is in the right place and when your intentions are grounded in doing what is best, it is felt. And that makes the whole process a lot smoother.
So do you have any additional advice or tips that you would share with any of our listeners who are interested in maybe creating their own organizational policies around radiopharmaceutical administration?
Absolutely. Be patient, be patient, be patient. Be open and really listen to all sides. Be creative and give people the space to be honest about what they think and what they need. One thing I teach in another class is Q-tip. Quit taking it personally. That mindset can change everything because it shifts the focus from ego to collaboration. If you can do these things, you can really build something that works, not just a policy, but a true collaborative, safe, and successful radiopharmaceutical program.
Well, Ella-Mae, thank you so much for joining us today on the podcast. This is a topic that we know is only going to continue to grow. And so this is a great example of new therapies, not just the ones that come out of medical oncology and the ones that we're sort of accustomed to on that side, but seeing these new therapies come out of the radiation space and how complex they are as well, and just what we can learn from each other, no matter what subspecialty of oncology we live in. It's great to hear you talk through your process. As we get to the end of our podcast, we like to always run through just a series of quick fire questions to help summarize some of the talking points that we've hit on today. To start that off, how do you think healthcare professionals should evaluate their sort of implicit or their hidden bias that they might hold about radiopharmaceutical policies and procedures?
Well, in my experience, one of the biggest sources of bias around radiopharmaceutical policies and programs is fear. And I get it. Radiation is a loaded word. And especially if you don't work in radiation oncology, people are often imagine danger and fear and contamination and worst case scenarios. But here's the thing. If you can address these fears head on and reassure people that the institution has strong safety protocols in place, that bias usually starts to dissolve. People just want to know that they and their families and their patients are safe. Sometimes I'll even use this example. Did you even know that a banana is slightly radioactive? Well, it's true. They contain potassium-40. It's a naturally containing radioactive isotope. We eat them all the time without a second thought. And radiation is just a natural part of our environment. And once people understand the science behind it, and more importantly, the safety practices that we built around it, they tend to settle in. So the fear fades and the biases soften. It becomes less about emotion and more about facts, trust, and teamwork.
What do you think are some common misconceptions about radiopharmaceutical policies and procedures?
Well, they're just written for the hospital to cover themselves, but they really are a place to protect you. And we have really made that an effort to protect staff and patients.
What's something about this topic that's not often discussed, but you wish people knew more about?
Radiopharmaceuticals generally emit low energy beta particles, which have a very short half-life range of exposure. It's just a few millimeters. And that means that the radiation doesn't travel far and poses very little risk when handled properly. We all take precautions and we use shielding, we follow layer principles, and ensure proper distancing. So, depending on your role and how close you are to the injection, your exposure is minimal to none. In fact, in all the time we've been administering these treatments, not a single staff member has had shown a high reading on their post-administry dosimetry. We also have safety badges in the treatment room and the hallways that monitor for any background activity. So even without a personal badge, you're still protected and monitored. The systems are in place to keep you safe.
What additional training or education do you think oncology nurses need to stay current on this topic?
Our staff have to do online radiation safety training, and then they have an in-person radiation safety officer training. And that's really important when they come on board. Additionally, online radiation safety training is done annually and separate from the hospital-wide annual bundle education. It's more specific to those areas that work in radiation areas. We're currently working on an online learning system for standardizing our radiation safety course and then breaking it down to little different pieces. Like I work in radiation oncology, I work in nuclear med, so that we can get more specific, but we are creating that right now.
And then finally, what are some resources that you would recommend for patients maybe or other providers who want to learn more?
ONS has several really good articles and information regarding radiopharmaceuticals, and I'm sure more is going to be coming with how expansive this is becoming. They are testing radiopharmaceuticals for pancreatic and breast and GU, and I really feel like they're going to be coming down the pike fairly soon and swiftly. Pluvicto has changed its guidelines to allow Pluvicto before chemotherapy, which has certainly increased our patient population. And the FDA inserts offer a lot of information, as do the company website. So if there's something I don't understand, I'll go to the company website and look it up. And if I can't find it, they have a help desk and you can always call and get some answers on those sites as well.
Well, Ella-Mae, thank you again for joining us today. It's been a great discussion about a really exciting treatment that's not brand new, but relatively new. And certainly, like as you mentioned, continuing to grow, and we'll see it more often for more patients, which is a wonderful thing. So thank you for sharing all of your expertise with us today. Do you have any final comments to share with our listeners?
Well, thank you for having me. This is such a passion of mine, and I think that knowledge is power. And when people have the knowledge, their fear can go away. But these are such an exciting treatment for our patients that's not chemotherapy, that's not radiation, and their quality of life has been amazing. We have had patients coming in that could barely walk because of the pain from bone mets, that after a few treatments, they're much better. We've had PSAs go from 500-600s down to 0.5. So we're seeing a lot of really good options for these patients and treatment variability that they can do. You know, even the older people can take this treatment and do very well with it.
Outstanding. Well, thank you again for sharing all your information with us today.
Thank you for having me.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.